So, general medicine. First topic that comes is screening. Wilson and Jungle criteria. The condition should be an important public health problem. There should be an acceptable treatment for patients with recognized disease. Facilities for diagnosis and treatment should be available. They should be recognized later or even early symptomatic stage. The natural history of the condition, including development from latent to declared disease, should be adequately understood. There should be a suitable test for examination. The test for examination should be acceptable to the population. All these. Lymphadenopathy causes can be generalized lymphadenopathy causes can be infective, neoplastic, and others. Infective is infectious mononucleosis, HIV, eczema with infection, rubella, toxoplasmosis, CMV, tuberculosis, roseola infantile. Neoplastic can be leukemia, lymphoma. Other causes can be autoimmune, SLE, rheumatoid arthritis, graft-versus-host disease, sarcoidosis, and drugs like phenytoin and, to a lesser extent, allopurinol isoniazid. The types of transplants: autograft, isograft, allograft, xenograft, orthotopic transplant, and heterotopic transplant. Autograft is when the same individual acts as a donor and recipient. So, like, same tissues from the same body can be transplanted somewhere else. Isograft when donor recipient are genetically identical. Allograft is when donor and recipient are genetically dissimilar but belong to the same specimen. Xenograft and donor recipient belong to different specimen. And orthotopic is when the transplant part is placed in its normal anatomical location. Heterotopic when the transplant part is placed in different anatomical location. Motion sickness describes the nausea and vomiting which occurs when an apparent discrepancy exists between visually perceived movement and the vestibular system sense of movement. Okay, motion sickness can give hyoscine or cyclizine or promethazine. This one is first. The BNF recommends hyoscine, transdermal patches being the most effective treatment. Use is limited due to side effects. Non-sedating antihistamines such as cyclizine or cynarizine are recommended in preference to sedating preparation like promethazine. Fitness to fly. UK Civil Aviation Authority has issued guidelines on air travel for people with medical conditions. Cardiovascular disease, unstable angina, uncontrolled hypertension should not fly. Uncomplicated MI may fly after 7 to 10 days. Complicated MI after 4 to 6 weeks. CABG patients 10 to 14 days. PCI after 5 days. Surgery travel should be avoided for 10 days following abdominal surgery. And laparoscopic surgery after 24 hours, colonoscopy 24 hours. Following the application for plaster cast, the majority of airlines restrict flying for 24 hours on flights of less than 2 hours or 48 hours for longer flights. For respiratory diseases, pneumonia should be clinically improved with no residual infection. Pneumothorax absolute contraindication may travel 2 weeks after successful drainage if there is no residual air. So this is very much contraindicated. Pregnancy, most airlines do not allow travel after 36 weeks for a single baby and after 32 weeks for twin. Most airlines require a certificate after 28 weeks confirming that pregnancy is progressing normally. Hematological disorder, patient with a hemoglobin of more than 8 may travel without problems. Altitude-related disorders. There are 3 main types of altitude-related disorder: acute mountain sickness, which may progress to high altitude pulmonary edema or high altitude cerebral edema. All 3 are due to chronic hypobaric hypoxia, which develops at high altitudes. Acute mountain sickness is generally a self-limiting condition. Features of AMS start to occur above 2,500 to 3,000 meters, developing gradually over 6 to 12 hours and potentially last several days. Headache, nausea, fatigue. Prevention treatment of AMS. It may be positively correlated to physical fitness, gain altitude at no more than 500 meters per day. Acetazolamide can help. Carbonic anhydrous inhibitor is widely used to prevent AMS. Treatment is descent. A minority of people above 4,000 meters go on to develop high altitude pulmonary edema or high altitude cerebral edema, potentially fatal conditions. Presents with clinical classical pulmonary edema features, and he is present with headache, ataxia, and papillary edema. The management of high altitude pulmonary edema is descent. Dexamethasone and nifedipine can help. Sildenafil can have oxygen if available, and haze is decent and dexamethasone. Next topic is clubbing. The cardiac causes can be cyanotic congenital heart disease, like Fallot's and tetralogy of Fallot and TGA, bacterial endocarditis, atrial myxoma. So respiratory causes can be lung cancer, fibrosing alveolitis, asbestosis, mesothelioma, pyogenic conditions like cystic fibrosis, bronchiectasis, abscess, empyema, all these. And other causes can be Crohn's to a lesser extent, ulcerative colitis, cirrhosis, primary biliary cirrhosis, Graves' disease like thyroid ectopathy, rare Whipple disease. Okay. Cartogenous syndrome. Primary ciliary dyskinesia was first described in 1933 and most frequently occur in examinations due to its association with dextrocardia. Quiet heart sounds small, volume complex in lateral leads. Incursions might be referred as wrongly labeled chest X-ray. Features can be dextrocardia or complete situs inversus, bronchiectasis, recurrent sinusitis, subfertility, secondary to diminished sperm motility and defective ciliary action fallibility. Okay, next topic is macroglosia. These are like very small topics. Cause can be hypothyroidism, acromegaly, amyloidosis, Duchenne muscular dystrophy, and Hurler syndrome, mucopolysaccharide. So hypothyroidism, acromegaly, amyloidosis, Duchenne muscular dystrophy, mucopolysaccharide. Patients with Down syndrome are thought to have apparent macroglosia due to a combination of mid-phase hypoplasia and hypotonia. What are the DVT risk factors that are there? Risk factors: hematological, vascular, drugs, stasis, and as well as autoimmune metabolic disorders. So, hematological risk factors are thrombophilia, activated protein C resistance, protein C S deficiency, polycythemia, paroxysmal nocturnal hemoglobinuria, hyperviscosity syndrome. So the hematological cause can be thrombophilia, polycythemia, paroxysmal nocturnal hemoglobinuria, or hyperviscosity syndrome. Drugs when we combine oral contraceptive third generation, not in second, and antipsychotic can also play a contributing factor, especially olanzapine. Autoimmune diseases can be antiphospholipid syndrome or basis disease. Vascular conditions may include previous DVT, varicose vein, CV, catheterization, smoking, and stasis, surgery, trauma, immobility, paralysis, age, pregnancy, postpartum, obesity, metabolic disorder, homocystinuria. And hyperhidrosis describes the excess production of sweat. Management include topical aluminum chloride preparation as first line. Main side effect is skin irritation and iontophoresis, particularly useful for patients with palmar, plantar, and axillary hyperhidrosis. Botulinum toxin, currently licensed for auxiliary symptoms. Surgery, endoscopic transthoracic sympathectomy can also be done. Management of confusion. Underlying cause of confusion needs to be looked for and treated as appropriate. And for example, infection, urinary retention, constipation, hypercalcemia, pain, and medication. All these can be there. If specific treatment failed, then the following might be tried. Haloperidol half milligram, not 5 milligram. Other options can be chlorpromazine or levofloxacin. In terminal illness, then dying patient, then agitation or restlessness is better treated with subcutaneous midazolam. Syncope might be defined as a transient loss of consciousness due to global cerebral hypoperfusion with rapid onset, short duration, and spontaneous complete recovery. Note how this definition excludes other causes of collapse such as epilepsy. Syncope can be classified as reflex syncope, like neurogenic, vasovagal, Like triggers like emotion, pain, stress, or orthostatic factors, often referred to as fainting. Situation like cough, mutilation, gastrointestinal, carotid sinus syncope. Carotid sinus hypersensitivity. Diagnosis only made after ischemic heart disease or rhythm disturbance has been excluded. This may be predominantly cardio-inhibitory, bradycardia, vasodilatory hypertension, or a mixture of the two. The cardio-inhibitor is usually managed with insertion of a dual-chamber pacemaker, and vasodilator is managed with support stockings, fludrocortisone, mitotine. Orthostatic syncope, primary autonomic failure, like Parkinson disease or Lewy dementia, can cause syncope. Secondary autonomic failure, like neuropathy, amyloidosis, uremia, drug-induced diuretics, alcohol vasodilator, uh, bone depletion, hemorrhage, diarrhea. Cardiac syncope, arrhythmia, like bradycardia, sinus node dysfunction, AV conduction disorder, or tachycardia, so ventricular. Structural can be valvular, MI, hypertrophic obstructive cardiomyopathy. Others can be pulmonary embolism. Reflex syncope is the most common cause in all age groups, although orthostatic and cardiac cause can become more common in older patients. Evaluation, cardiovascular examination, postural BP readings, symptomatic fall in BP, systolic BP more than 20 or diastolic BP more than 10, or decrease in systolic BP less than 90 is considered diagnostic. ECG, carotid sinus massage, and tilt table test, 24-hour ECG. These are the evaluations. UTI. Lower UTI infection in women, cystitis. Local antibiotic guidelines should be followed if available. Clinical knowledge summarizes recommend trimethoprim or nitrofurantoin for 3 days. Asymptomatic bacteriuria in pregnant women, treat with amoxicillin or cephalosporin. Pregnant women. LUTS, lower urinary tract infection pregnancy. Asymptomatic bacteria is screened for on the bookings visit and should be treated with an antibiotic for 7 days. Sensitivities should already be available. For acute lower urinary tract infection, consider amoxicillin or cephalosporin for 7 days for pregnant women. And acute pyelonephritis, hospital admission should be considered. Local antibiotic guidelines should be followed. BNF considered the broad spectrum and cephalosporin for quinolone for 10 to 14 days. Clinical knowledge summaries recommend ciprofloxacin for 7 days or coaxiglove for 14 days. CKS also mentioned the use of trimethoprim and nitrofurantoin. Trimethoprim is a folate antagonist, and concerns have been raised regarding the potential use of neural trip defects. Manufacturers have advised to avoid it. While short-term trimethoprim use is unlikely to cause folate deficiency, it would seem reasonable to use an antibiotic such as amoxicillin first line. Nitrofurantoin should be avoided at term because of the risk of neural hemolysis. Nitrofurantoin. Next topic is monoclonal antibodies. This keeps up coming up in the exams. Have an increasing role in medicine. They are manufactured by a technique called somatic cell hybridization. This involves the fusion of myeloma cells with spleen cells from a mouse, recent advances of rabbit beta cells, that has been immunized with the desired antigen. The resulting fused cells are termed as a hybridoma and act as a factory for producing monoclonal antibodies. The main limitation to this is that the mouse antibodies are immunogenic, leading to the formation of human anti-mouse antibodies (HAMAs), and the problem is overcome by combining the variable region from the mouse antibody with the constant region from a human antibody. Monoclonal antibodies are also used for medical imaging when combined with radioisotope and identification of cell surface markers in biopsy tissue, diagnosis of viral infection. So for the types of monoclonal antibodies, you see rituximab anti-CD20 uses non-Hodgkin lymphoma. You've already seen this in your hospital. Infliximab anti-TNF, tumor necrosis factor, rheumatoid arthritis and Crohn's disease can be useful for this. Cetuximab anti-epidermal growth factor receptor, metastatic colorectal cancer and head and neck cancer. Trastuzumab anti-HER2, anti-EGF receptor, metastatic breast cancer. Do echo regularly because it can cause cardiomyopathy. Alemtuzumab anti-CD52, CLL, abciximab, anti-glycoprotein 2b3A receptor undergoing PCI, prevention of ischemic events in patients, OKT3, anti-CD3, prevent organ rejection. So all these monoclonal antibodies are important to remember. Coming to general oncology, so there will be some specific topics here that will be reviewed. Cancers in the UK excludes non-melanoma skin cancer. Most common cause of cancer is breast cancer, lung cancer, colorectal, prostate, bladder, non-Hodgkin lymphoma, melanoma, stomach, esophagus, pancreas. And most common cause of death is lung, colorectal, breast, prostate, esophagus, stomach, bladder, non-Hodgkin's lymphoma, ovarian, leukemia. So lung and colorectal. Breast. So it's like LCB, and this is BLC. Prostate is always 4. Okay, tumor markers may be divided into monoclonal antibodies against carbohydrate or glycoprotein tumor antigens, enzymes, and hormones. These 4 are the tumor markers: hormones, enzymes, tumor antigen, monoclonal antibody. Should be known that the tumor marker usually have a low specificity. And monoclonal antibody like tumor marker CA125 ovarian cancer, CA99 pancreatic cancer, CA15-3 breast cancer, and tumor antigens that are there. These are the monoclonal antibodies. Remember that. And the tumor markers are PSA, prostatic carcinoma, AFP, alpha fetoprotein, hepatocellular carcinoma, teratoma. CEA is like colorectal carcinoma. Next is thymoma. What is thymoma? The most common tumor of the anterior mediastinum, associated with myasthenia gravis, 30 to 40% of the time. The patient with thymoma, red cell aplasia, dermatomyositis, SLECR. Causes of death can be compression of airway and cardiac tamponade. Testicular choriocarcinoma are rare. Diagnosis: primary tumor can be very small and go undetected on testicular examination. Marked increase in beta HCG in the presence of normal AFP and CEA. Testicular choriocarcinoma. Okay. Scrotal ultrasound is used to support the diagnosis. CTs are of significant value for staging. Management: choriocarcinoma is extremely sensitive to cisplatin-based chemotherapy. Cisplatin, with cure rates up to 80% being achievable given even in advanced disease. That's good. Superior vena cava obstruction is it's an uncommon manifestation of mediastinal mass, but it's particularly for small cell lung cancer. Treatment depends on the cause and the pace of the progression of symptom. Although SVCO is an emergency in the presence of airway compromise, where possible, it's important to get tissue for a histological diagnosis. Some tumors are better treated with chemotherapy than radiotherapy. In this case, if feasible, bronchoscopy would probably provide tissue for a diagnosis. For most tumors, radiotherapy is a good treatment, and but always so you need to get some tissue for histological diagnosis. For most tumors, radiotherapy is a good treatment and relieves symptoms in 90% of patients. So radiotherapy is also good for most tumors. Patients should be sat up and given oxygen to provide initial relief. In severe cases, high dose IV steroid can be helpful. For patients with recurrent superior vena cava obstruction, insertion of an expandable wire stent under radiological guidance provides relief in a high proportion of patients. Okay. So the next topic is hereditary multisystem disorder. This is also important and often is overlooked during the exams. So this needs to be revised on a daily basis so that it's not ignored during the exam. Okay, so what's porphyria? It's abnormality in enzyme responsible for biosynthesis of heme. So it's all down to hemoglobin. That's where porphyria occurs. Results in overproduction of intermediate compounds like porphyrins. That's why it's called porphyria. So abnormality in the enzymes responsible for the biosynthesis of heme. Okay, maybe acute or non-acute. All porphyrias has autosomal dominant inheritance except congenital porphyria. So it's usually AD. And Only the acute porphyrias develop neurological consequence. Can have neurological symptoms. All porphyrias are photosensitive except AIP. If it's inherited or congenital, it's extremely rare, unlikely to be the answer. So what happens is there is an enzyme a problem in the biosynthesis of hemoglobin, okay, hem, which is responsible for hemoglobin. So how can you see it? Urinary porphyria is increasing in all three types, and fecal porphyria is increasing in variegate porphyria and hereditary porphyria. So the one which is more very much common is acute intermittent porphyria. It's also AD, as said before. Defect in porphyrinogen deaminase. Porphyrinogen deaminase defect is an enzyme, results in accumulation of delta aminolevulinic acid and porphyrinogen. Accumulation of these two can occur, and females 20 to 40 years old more likely to be affected. Female more than male, 5:1 ratio, and typically present with abdominal symptoms, neuropsychiatric symptoms, hypertension, and tachycardia common. Urine turns deep red on standing. This may be mistaken for hematuria. So on standing, urine will turn deep red. Okay, so what can be the features of AIP? Abdominal pain and vomiting, very common features. Neurological features can also be there, as said before, motor neuropathy. Psychiatric like depression, hypertension, tachycardia are also common. No feces porphyria can be treated in stool. Diagnosis classically urine turns deep red on standing, raised urinary porphyrinogen, and increase between attacks and turbulent erection during acute attacks. Assay of red cells for porphyrinogen deaminase, increased level of delta aminolevulinic acid and porphyrinogen. So this is the diagnosis. So urinary porphyrinogen is increased, the deep red assay of red cells. Okay, management will be hematin. Needs to be given very early in attack to be effective. Effectiveness varies among individuals. They are not curative, but can shorten attacks and reduce the incidence of an attack. Porphyria cutaneous tarda, non-acute. Most common hepatic porphyria. 80% is sporadic and 20% is autosomal dominant. So porphyria cutaneous tarda is non-acute. It's not the acute version. Most common hepatic porphyria. 80% is sporadic and 20% is autosomal dominant. No neurological consequences. Only urine porphyria. And the exact frequency is not clear because many people with PCD never experience symptoms. So the defect in uroporphyrinogen decarboxylase. So deaminase was that, and this is decarboxylate. Porphyrinogen deaminase was AIP, and here it's defect in uroporphyrinogen decarboxylase, may be caused by hepatocyte damage. Alcohol estrogens, classically photosensitive rash with bulla, skin fragility on face, and aerosol aspect of hands. Urine elevated uroporphyrinogen and pink fluorescence of urine under Wood's lamp. PCT. Managed with chloroquine. So what you remember is AIP for porphyrinogen deaminase. This defect in this thing, and for PCT is uroporphyrinogen decarboxylate defect in this thing. Variegate porphyria acute, autosomal dominant as well. Defect in protoporphyrinogen deoxidase for the sensitive blistering rash, abdominal and neurological symptoms more common in South Africans. Okay, next topic is galactosemia. So galactosemia is a rare autosomal recessive condition caused by absence of galactose-1 phosphate uridyl transferase. This results in intracellular accumulation of galactose-1 phosphate. So what happens is jaundice, failure to thrive, hepatomegaly, cataracts, hypoglycemia after exposure to galactose. Fanconi syndrome can also occur. Diagnosis urine reducing substances. Management is with a galactose-free diet. Hereditary angioedema is an autosomal condition. Autosomal dominant condition associated with low plasma levels of C1 inhibitor. Uncontrolled release of bradykinin resulting in edema of tissues. So low C1 inhibitor, so increased bradykinin. So edema of tissues. Investigation is C1 INH level is low. Low C2 and C4 levels are also seen even between attacks. Symptoms may be attacks may be preceded by painful macular rash and painless non-periodic swelling of subcutaneous submucosal tissues. May affect upper airway, skin, abdominal organ. Can occasionally present as abdominal pain due to visceral edema. Urticaria is not usually a feature. So something is only swelling and painless swelling, and also and maybe rashes there. Acute IV C1 inhibitor concentrate or FFP, anabolic steroid or danazol may help. Alpha 1 antitrypsin deficiency. Uh, so it's a common inherited condition caused by lack of protease inhibitor PI, normally produced by the liver. So it's normally produced by liver. Located on chromosome 14, alpha 1 antitrypsin deficiency inherited as an autosomal recessive fashion. Alleles classified by the electrophoretic abnormality. M is normal. M is normal. Mobility is electrophoresis. M is normal. S is slow, and Z is very slow. So this is something you have to remember, that M is normal, S is slow, and SZ is very slow. It's in alphabetical order, like M before S before Z. So it's faster and slower. So normal is PIM, M is normal, and then homozygous PISS is 50% normal at alpha 1 antitrypsin levels, and PIZZ is 10% normal at alpha 1 antitrypsin level. Okay. So features can be patients who manifest this usually have PIZZ phenotype, very slow, alleles, mobility, lungs, pan-acinar emphysema, most marked in lower lobes, and liver cirrhosis and hepatocellular carcinoma in adults, causes in children. HCC in adults and causes in children. Skin necrotizing panicolitis. Necrotizing panicolitis, systemic vasculitis, psoriasis, urticaria, angioedema, liver, cirrhosis, neonatal hepatitis, hepatocellular carcinoma, kidneys, proliferative glomerulonephritis, IgA nephropathy, intestinal inflammatory bowel disease, lungs, COPD, pan-acinar emphysema, bronchiectasis, and asthma. And vascular can be ANCA-associated, ANCA-positive vasculitis, abdominal intracranial aneurysm, arterial fibromuscular dysplasia. Investigation alpha 1 antitrypsin concentrations. Management can be no smoking, supportive like bronchodilator physiotherapy, intravenous alpha 1 antitrypsin protein concentrates, surgery, volume reduction surgery, lung transplantation. Alpha 1 antitrypsin levels in the blood depend on the genotype. Some mutant forms fail to fold properly and are thus targeted. Okay, so alpha 1 antitrypsin levels in the blood depend on the genotype. Okay, so and alpha 1 antitrypsin levels in the blood depends on the genotype. Some mutant forms fail to fold properly and are thus targeted for destruction in the proteasome, whereas others have a tendency to polymerize, being retained in the endoplasmic reticulum. The serum levels of some of the common genotypes are analysis. Questions around this will require you to roughly calculate how much normal is available to determine the type. So PIMM is like normal. PIMS is basically 80% of normal serum level, like M is there. PISS a bit slow, so 60% is normal, and PIMZ 60% normal as well. PISZ is like 40% normal. The PIZZ is like severe alpha 1 antitrypsin deficiency. So, young patient with progressive shortness of breath, jaundice, signs of COPD, physical examination, X-ray, likely liver cirrhosis, ultrasound. So that's alpha 1 antitrypsin deficiency, or as well as young age, progressive shortness of breath, and limited history of smoking, plus pulmonary function test indicative of COPD, hyperinflation of lung, alpha 1 deficiency. So COPD, jaundice, and liver cirrhosis. Very strange combination, but it's like suggestive of alpha 1 antitrypsin deficiency. Next topic is about ENT topics, tinnitus. Um, so clinical science, I'm involving all the general topics in clinical science as well because this doesn't fall under any category. So yeah, it should be addressed because a lot of questions also come from here, and then when they come, like you're wondering like what they come from. So this general medicine, oncology, these stuffs are there as well. Okay, ENT related conditions like tinnitus. Causes can be Meniere's disease, hearing loss, and others. Meniere's disease is associated with the hearing loss. Tinnitus and sensation of fullness or pressure in both one or both ears. Vertigo is the most common prominent symptom. Hearing loss causes include excessive loud noise and prebiscus. Uh, Atherosclerosis onset is 20 to 40 years. Conductive deafness, tinnitus, normal tympanic membrane. 10% may have a flamingo tinge. Hyperemia, acoustic neuroma, hearing loss, vertigo, tinnitus. Okay, acoustic neuroma, hearing loss, vertigo, tinnitus, absent corneal reflex is important sign, and associated with neurofibromatosis type 2. So meningitis is something important. If you remember that is hearing loss, fullness of pressure in one or both ears, vertigo is prominent symptom. So these three are the main thing: fullness, vertigo, and also hearing loss is due to loud noise. Otosclerosis can be conductive deafness. Tinnitus is there, and yeah, flamingo tinge. Drugs: aspirin, aminoglycoside, loop diuretics, quinine, and impacted earwax, chronic suppurative otitis media. This can also be there. So let's go to Meniere's disease that we studied before. A disorder of the inner ear of unknown cause. It's characterized by excessive pressure and progressive dilatation of the endolymphatic system. And it's more common in middle-aged adults, but maybe seen at any age. Meniere's disease has a similar prevalence in both men and women. Features can be recurrent episodes of vertigo, tinnitus, and hearing loss. So this VTS, vertigo, tinnitus, hearing loss, and general vertigo is usually the prominent symptom. A sensation of all fullness or pressure is now recognized as being common. Other features include nystagmus and positive Romberg test. Mm, Patient can't stand alone when eyes closed and fit together. So recurrent episodes of vertigo, tinnitus, and hearing loss, and there's fullness or pressure. And then there's other features can include nystagmus and the positive Romberg test, where patient can't stand on one eyes are closed and fit together. Episodes last minutes to hours. And natural history. Symptoms resolve in most patients after 5 to 10 years. Some patients may be left with hearing loss. Psychological distress is common. ENT assessment is required to confirm the diagnosis. The patient should not inform the DBL. The current advice is to cease driving until satisfactory control of symptoms is achieved. Acute attacks, buccal or intramuscular prochlorperazine. Admission is sometimes required. Beta-histine may be of benefit. Okay. The next topic is it's almost over for ENT. Otitis externa. It's a common reason for primary care attendance in the UK. Infection, bacterial like Staphylococcus aureus, Pseudomonas, seborrheic dermatitis, contact dermatitis. Pseudomonas aeruginosa cause malignant otitis externa. Features can be earache, leech discharge, otoscopy. Features ear pain and itch and discharge. Otoscopy shows red, swollen, eczematous canal. Initial management: topical antibiotic or a combined topical antibiotic with steroid. Uh, if the tympanic membrane is perforated, amyloid should not be used. If there's canal debris, then consider removal. If canal is extensively swollen, then an air wick is sometimes inserted. Second line options include consider contact dermatitis secondary to neomycin or antibiotic with infection spreading, swab from ear, empirical use of antifungal agent. Malignant otitis externa is more common in elderly diabetics. In this condition, there is an extension of infection into the bony ear canal and the soft tissue deep to the bony canal. Okay, the next is Viennese and Weber's test. Uh, it allows differentiation of conductive and sensory neural deafness. And Viennese test is basically put a tuning fork over the mass fat process at the back of the head, followed by repositioning just over the ears. So air conduction is normally better than bone conduction. So when you put the tuning fork in the bone mass fat process, it's supposed to stop after a while, but and then when you place it in front of the ear, you can still hear the vibrations. That's normal. But if bone conduction is more than air conduction, so that's when it's conductive deafness. And Weber says his tuning fork is placed over the middle of the forehead, and patient is asked which side is loudest. In unilateral sensory neural deafness, sound is localized to the good side. One-sided sensory neural deafness, sound is localized to the good side. And unilateral conductive deafness, sound is localized to the bad side. So Weber's Sun Cafe, how do you remember this? Sensory neural unaffected ear and conductive affected ear. Okay, Sun Cafe, that's how I remember. BPPV is one of the most common cause of vertigo encountered. It's characterized by the sudden onset of dizziness and vertigo triggered by changes in head position. So vertigo triggered by change in head position, rolling over in bed or gazing upwards, may be associated with nausea. Each episode typically lasts for 10 to 20 seconds, and positive Hall-Pike maneuver, Dick's Hall-Pike maneuver is in. And PPV has a good prognosis and usually resolves spontaneously after a few weeks to months. And symptomatic relief may be Eplis maneuver, successful in around 80% of cases. Medication is often prescribed betahistine, but it tends to be of limited value. So that's the end of clinical science.